Um, Welcome, members and guests. I'm Kenichi Kejima from Juntendo University, Tokyo, Japan. I'm chairing the session MAFLD 4, Clinical Management of MAFLD, Lifestyle Change, Nutrition, and Need of Medications. And my co-chair is Dr. Umemura and Dr. Hu, but unfortunately they're not here now. So I'd like to start the session. The first speaker is Dr. Diana Alcata Payawal from the Department of Internal Medicine Faculty, Fatima University Medical Center, Hepatology Committee, Cardinal Santos Medical Center, Philippines. Dr. Alcata Payawal, please.
Thank you very much. It's indeed an honor to be invited, and I'd like to thank the organizing committee for this kind invitation. So I was given the task to give you an integrative approach to MAFLD, a comprehensive strategy for care and management. I have nothing to disclose related to this study. So let's start with the fatal trio. The fatal trio is actually a conglomeration of obesity, type 2 diabetes mellitus, and cardiovascular disease, which are all closely linked with and an impact with each other. And therefore, obesity plays a significant role, as evidenced this morning by our speaker, plenary speaker, which is a significant risk factor for MAFLD. And therefore, its exposure is actually directly related to the increased risk of liver cancer. Out of the obesity, about 52% of patients with type 2 diabetes do have MAFLD, and the presence of MAFLD in patients with type 2 diabetes actually hampers the glycemic control, and this requires multiple and anti-diabetic therapies and increasing the risk both for micro and macrovascular complications. Having said this fatal trio, these are the issues of concern I'd like to tackle today. Address MAFLD as a multi-system disease, its role in metabolic syndrome, identify the gaps and challenges among patients with MAFLD. Let's start with the metabolic syndrome. 14.3% of these patients are actually known to have metabolic-associated fatty liver disease, and out of this, as you increase in the number of metabolic syndrome criteria, you also increase the prevalence of fatty liver disease. Out of this, 4% of these patients on analysis have already advanced fibrosis. So this clearly states that on patients who both have the more of the factors or most of the criteria for metabolic syndrome, the risk for fatty liver disease increases. So in essence, you have a patient with a healthy liver, and because of lifestyle, develops steatosis, and of course, NASH with or without fibrosis. Out of this, you have patients who have insulin resistance or hyperinsulinemia, patients who develop vasoactive and thrombogenic molecules that are increased, and this is the increase in fibrinogen and transforming growth factor beta. And with this, you have a pro-inflammatory state of these patients who have increased interleukins and, of course, a C-reactive protein that is quite increased. Because of this inflammatory state, these patients now do develop either cardiovascular disease and, of course, are related to arrhythmias, type 2 diabetes, chronic kidney disease, and, of course, a risk for colorectal cancer. Now, whether this is actually bidirectional is something that we need to see in the next few slides. So as I mentioned, because of a patient with MAFLD, you have an increase of your inflammatory cytokines. You have already an expanded and dysfunctional adipose tissue, which increases the free fatty acids. And this is sort of a circular pattern, as your patients do have an increase of these inflammatory cytokines. Along with this, you can see on the left side of your screen, patients who develop myocardial steatosis and increased pericardial fat, and you develop now a patient on this subsequent. Patients who have insulin resistance, atherogenic dyslipidemia, patients who have a hypercoag state, as well as arterial hypertension. This all adds up to a patient with cardiac autonomic dysfunction, producing now a patient who have cardiovascular disease. Now, this concept has been challenged and tried to see whether patients who do have metabolic associated factors do end up with cardiovascular adverse outcomes. Along with this, a meta-analysis of 36 longitudinal studies have shown that in a follow-up of 6.5 years, which involves almost 5 million students or 5 million people, you can see that MAFLD confirmed is associated not only with an increased risk factor for non-fatal, but also for fatal cardiovascular events. And when you look at it closely, on the rank of the different, on the left side is the rank, and how these patients end up. They do end up with liver-related cirrhosis, but what is interesting in both studies is that cardiovascular risk factors does end up on the first of these patients. So you can see clearly that if you take care of patients with MAFLD, you need to also have a cardiologist with you on hand, because you need to look at the risk factors for cardiovascular disease and manage them accordingly with the age-appropriate cancer screening procedures. Notwithstanding the fact that the second cause of death among these patients is extrahepatic malignancy, and that is why colorectal cancer are those patients who may develop also in MAFLD, and of course, accidents and endocrine disorders. So looking at it closely on a broader perspective, you can see here, as I mentioned, a patient who has increased free fatty acid. This then ends up with a patient on pro-inflammatory increase or pro-atherogenic molecules, which thus increases patients who develop now the so-called metabolic associated fatty liver disease and NASH, producing more on an inflammatory state and increased reactive oxidative stress. So this bidirectional MAFLD is what becomes an outcome of patients with metabolic disease. You have in the middle a patient with metabolic associated fatty liver disease, increasing now the vasoactive thrombogenic molecules, producing now a cardiovascular endpoint. Along with that, you can have patients who have developed high blood pressure, dyslipidemia, pre-diabetic, patients with an altered lipid and glucose metabolism, a pro-inflammatory state, and obesity, producing now a bidirectional pattern or relationship between the metabolic factors and, of course, MAFLD. So the interplay acts as an independent risk factors that you now promote more of the atherogenic dyslipidemia and pro-inflammatory and pro-fibrogenic and pro-coagulant systemic environment. This then produces us to rethink that we need to have a multidisciplinary study or multidisciplinary team to take care of patients with metabolic associated fatty liver disease. So how do you do it in perspective? You have a patient who assessed to have the risk factors. Type 2 diabetes, patients with metabolic syndrome, obesity, or any patient who developed an incidental hepatic steatosis on ultrasound or even an abnormal aminotransferase. Of course, it's evident that you have to exclude other causes. So in a resource-limited country wherein you cannot actually do certain strategies like FibroScan, you may start with the first assessment of FIB-4. And if your FIB-4 is as follows, then if your FIB-4 is less than 1.3, this is a low risk, and the recommendation is actually to repeat the NITs in 2 to 3 years. However, if your FIB-4 is about 1.3 to 2.67, which is in the gray zone, the recommendation is to do, of course, a liver stiffness measurement or an ELF score. And if your ELF liver stiffness measurement is about 8 to 12 kilopascals, the recommendation is recommend patient for a specialty care. And at the end of the spectrum, if your patient is in the FIB-4 more than 2.67, then you go for a high risk or specialty care. So what are the treatment strategies? There are actually a conglomeration of the three, the fatal trio that I say, and basic to it is lifestyle. So you can see here that there are different recommendations of our different big associations. As mentioned this morning, we are redoing the MAFLD guidelines. And here you can see program, diet, weight loss, exercise, and bariatric surgery. Of course, lifestyle is evident, and that is both changing or the dietary change, the weight loss, and a structured exercise system. Let's try to see the evidence behind it. For weight loss, the recommendation is, of course, the 7 to 10 reduction, which leads to not only the resolution of steatosis, but also the improvement of fibrosis. This is the well-rounded landmark study of a prospective study of 293 patients who were given a caloric deficit of 750 kilocalories per day and a moderate intensity exercise, showing now that when you actually degrade or reduce your weight by 7 to 10%, you can have a resolution of both NASH and, of course, fibrosis. Now, what about the diet and exercise? You can see here that the well-recommended Mediterranean diet, consisting of vegetables and, of course, nuts and less of the red meat, recommends that in the intervention arm versus the no intervention arm, this is quite a short duration of study, but it was already able to show a decrease in intrahepatic fat of almost even in short term at 6 months to even a long-term study of 8 months, showing that you now have a recommendation to adhere to the Mediterranean diet. But of course, in Asia, most of us in our, like in the Philippines, we are mostly vegetable eaters and fish, being in a tropical country, and probably this will have a nick, of course, in our diet. So just to show you that vegetables and fruits, whatever book you have read, will always tell you that it actually is related to a very good outcome. So what are the approaches for available therapy? As I mentioned, weight loss, diet, control of the other metabolic parameters, and this is the anti-hyperglycemic agents that both promote weight loss. So it's not the drug itself, but the weight loss it produces, and of course, bariatric surgery. The other approaches, the statins, to reduce the portal pressure, the metformins, these are actually conflicting data, and treat the type 2 diabetes, which is evident. You have to keep your numbers down, your hypertension, your dyslipidemia, and of course, you have to stop smoking. And of course, you target NASH, and this is the 2 studies that have been shown. So, as I mentioned, and this is evidenced by the title itself, it is the integrated care. So both primary and secondary, we have here patients who actually come to us and in the primary care physicians, and the recommendation is actually only do secondary care with specialist care if your patient falls in the high-risk population. So just to know that in some centers, they do away already with abdominal ultrasound and go straightly to the measurement of fibrosis if your patient has the risk factors that were associated or that were mentioned. And this is obesity, metabolic factors, or syndrome, and type 2 diabetes. They would screen for liver function. And of course, if there is already an evidence, you can go straight to analysis of fibrosis, because that would tell you who are the patients you would probably be taking care of as specialists, and who you would go back and bring back the patient to primary care physician for us to be monitoring them in due time. So here you can see that secondary care is turned out to be patients who actually work with the dietitian and of course the internist. The internist keeps a role in the intensive treatment of type 2 diabetes in patients who follow up every 3 years with non-invasive tests if it is actually available in your center. So this multidisciplinary approach, as your patient nears the end of being a patient-centered and holistic approach, hypes on the internist, the cardiologist, the nephrologist, diabetologist, hepatologist, your dietary and lifestyle coach, and of course your general practitioner. All of this moves together in a metabolic or isolation or control of the comorbidities, and of course this would improve outcome. So in essence, you have to evaluate this is the approach to multidisciplinary team. You have to evaluate the patient benefit and cost effectiveness. In some countries, which is out of the pocket, when you pay every specialist that you see, then probably an internist would work along that line, and you can manage this patient and refer only for specific isolated cases that need specialty care. So this is based on a model of care based on non-invasive tests, which should be adopted as the first-line providers. Now that we are nearing, like in my country, we are going more for universal health care, this probably would work in the primary care setting, isolating and educating our primary care physicians to take care of our patients and only refer patients on complicated cases. We implement the context of prevention. I think this is evident by both lifestyle modifications, screening and risk stratification of fibrosis, and eventually treatment of comorbidities. And of course, in a resource-limited country like Asia or region like Asia, models of care and consistently report their activities or effectiveness if there is a need. And of course, develop and provide clear, simple guidelines that will be relevant for professional societies and regarding preventive hepatology and specific criteria. And lastly, of course, deliver models that must come over time with constraints and if primary care physician and other doctors by decreasing the human burden. So this is my summary slide, Mr. Chair. MAFLD is a complex and multisystemic disease that requires both a multidisciplinary approach to prevention, diagnosis, treatment, and care. So in other words, when you identify patients with MAFLD, there should be an access to both not only care, but also to the drugs that will be evident in controlling the comorbidities. And while MAFLD-specific treatment doesn't exist, and still nears a lot of data to come in, a structured lifestyle and intervention and medications of comorbidities. I mentioned that cardiovascular is the first cause of death as well as extrahepatic malignancies, and therefore monitoring for these patients should be evident. This can have a positive effect and may have different stakeholders and should play a role in preventing health outcomes. And lastly, of course, it's not only a bottom-up, but also a top-down strategy, a bottom-up, wherein we have to take care of the community physicians with critical factors in community setting and developing models of care, as well as top-down, wherein policies of the government have to be there and national, both in national and global strategies, which seems to be the key mechanism. With this, I'd like to thank you, and I'm happy to take questions.
Thank you very much for comprehensive presentation regarding the MAFLD. Now this presentation is open for discussion. Any question and comments from the audience? Yes, please.
Correct. Yes, sir. Yes. This is the minimum number or a percentage that you would achieve a significant reduction in fibrosis. What you are talking is the end outcome, which is a cardiovascular endpoint. Yes, of course, in patients who have cardiovascular risk factors, the recommendation is actually to hit a higher weight loss. But the endpoint that was used in the study is reversibility of steatosis and reversibility of fibrosis, which is already achieved if you actually get a 7 to 10%. So I think that's a good way to start telling your patient. If your patient actually cannot achieve, telling them to achieve 50% of their weight or maybe 30% of their weight is quite difficult. But if you tell them, when you achieve a 10% weight loss, you can have a reduction of your risk for fibrosis. I think that would be a welcome strategy for our patients. So in other words, sir, I think it's a slow way of doing things in a perspective way.
Hi, Dr. Okanoue, please.
Yeah, I am a discussant. I am a kind of it. So as you pointed out, the risk factors of the development and the progression of MAFLD is very heterogeneous. And in Japan, around 1/3 of the MAFLD patients is non-obese. So how do you think about the dietary treatment or training for those non-obese patients in MAFLD patient?
Okay, I have taken care of patients who have a normal risk and yet they do develop MAFLD. My take on that is probably we're seeing them quite early, and in due time they may develop also diabetes and obesity. So the strategy that would recommend is actually to do preventive studies or preventive strategies as early as that so that they will not develop the risk of obesity, of diabetes, and of course dyslipidemia. So in other words, sir, maybe it is bidirectional. It can produce such an issue, and if you do preventive care early on, the risk of these patients might not develop.
Thank you.
Hi, please.
Hi, Catherine from Australia. Thank you for a wonderful talk. As you probably know, lifestyle change probably is associated with 5 to 7% weight reduction. It's not always durable. What role do you think more aggressive pharmacotherapy for weight management and bariatric surgery has in this treatment paradigm, and should gastroenterologists be using them more?
Yes, there are a lot of drugs now that are hitting on obesity. In fact, drugs that are aimed for diabetes, whose side effect is to actually have reduction of weight, are being used for NASH. My take on that is that there's no harm in putting our patients on such, especially if you feel that there are already endpoints or target organs that are being involved already in specifically. So my key message here is, of course, that's why I only hyped on what has evidence, and that is weight loss. So if you achieve weight loss with a good coach, an exercise coach, or probably a good dietitian, or probably drugs that can help, because maintenance is quite an issue also in such a scenario, that would be a welcome strategy. In other words, a multidisciplinary team that aims to keep your patient on reduction of weight for obese patients, even if it entails bariatric surgery, I think that's a welcome idea.
Yes.
I'll just second that. But would it be better that you classified them right from the very go? Because it's very frustrating for the patients as well as the physicians that the patients don't lose weight, even if they lose weight. So what I'm saying is, if we classified obesity grade 1, 2, and 3, rather than waiting for the other measures not to help, we can actually directly proceed to giving them medications or doing a surgery, because most of these with grade 2 and grade 3 obesity, these lifestyle modifications, all those things won't work.
Yes, that's a good strategy, sir. I mean, there are a lot of ways that we can aim for to reduce the need of drugs. Yes, I think that's a welcome strategy. In fact, in a resource-limited country, I was reading that not doing ultrasound already is a key factor. Like the Philippines is an archipelago, and being an archipelago, it's difficult for our patients to come back and forth. So I think strategies like this will help us.
I have one question. In terms of dietary factor, you emphasize that Mediterranean diet has some beneficial effect. But there are a variety of diet worldwide, and we believe that Japanese food is somewhat healthy, but still the evidence is not enough. But how about the situation in the Philippines?
Oh, we are meat eaters, and even if we're a tropical country, our standard menu involves lechon, which is a pork that is roasted, and this is done every parties or every Christmas, or like now it's going to be Easter in the next few days. So I think, sir, strategies of changing cultures is something that is a challenge. Especially as far as diet is concerned. I only included Mediterranean diet because that's the one with evidence. But I guess having stayed here, I took my postgraduate course here in Todai, and I lost weight that time. So I think that was a
do you
very good
recommend
strategy.
Mediterranean diet in your country?
We have our Filipino diet based on vegetables, but as I mentioned, cultural impact plays a significant role, and I guess that holds true for a lot of countries too.
Maybe we need to discuss more about the cultural issue, especially in the Asian countries.
Yes, yes.
So we have a variety of diet.
Yes,
And we need clinical evidence for that.
we are doing the Apostle Guidelines for Nutrition, and I do hope that it will incorporate the regional differences or the cultural differences when we do come up with our strategies.
And one more point is, you also mentioned about the mortality risk is high in cardiovascular disease. But in Japan, the nationwide studies show that cardiovascular risk is not highest, but rather liver-related deaths is very important.
Yeah,
so there's certain ethnic difference.
Correct.
But how about in Philippines?
In my country, most of our patients who are MAFLD are diabetic and has a cardiovascular risk. So I think even if
So in your country,
in my
it's
country,
similar
number
to the
one
United
is
States.
yes. We have a lot of fast foods around, and even if you say cardiovascular disease and ischemic heart disease is the number one cause of death as far as of diseases are concerned. So it's still a major issue for us.
All right. Thank you very much. So thank you again for your nice presentation.
Thank you.
I've just informed that unfortunately Dr. Uemura has flu, so he cannot come over to the session. Anyway, so I'd like to introduce next speaker, Dr. Min Lun Yu from National San Yat-sen University and Kaohsiung Medical University, Taiwan. His talk is clinical management of MAFLD. Dr. Yu, please.
Thank you very much, Mr. Chairperson. Good afternoon, ladies and gentlemen. It's my great honor to be invited here to touch the lifestyle modification with NASH and cardiometabolic dysfunction. As shown by Professor Diana Payet, you know that there are broad spectrum of the MAFLD. Around 25 to 30% of people are living with non-alcoholic fatty liver disease worldwide. And all these patients with MAFLD, around 25 to 30% will emerge into so-called NASH, non-alcoholic steatohepatitis, and then progress to NASH fibrosis, and eventually cirrhosis, hepatocellular carcinoma, and liver-related death. So what you have to do in clinical practice is try to block the progression from MAFLD to NASH to NASH cirrhosis, and even to prevent the HCC development. However, the MAFLD and NASH is not only associated with the end-stage liver disease, but also strongly associated with cardiometabolic comorbidities and severe mortality. Around 80% of the patients with NASH will have at least one comorbidity, including obesity, hyperlipidemia, hypertension, type 2 diabetes. And also 40% of NASH patients will progress into advanced fibrosis, and the risk factors, including the men and postmenopause women, obesity, type 2 diabetes, and genetic disposition. Once the fibrosis is established, the risk of all-cause mortality increase with the stage of fibrosis, such as when compared to MAFLD without fibrosis, the patient with stage 1 NASH will have a rate ratio of 1.6, of all-cause mortality and increased to 6.4 in the ratio of the all-cause mortality. So the main case, and so the major case of the deaths are not the liver disease, but the CV event and all-cause mortality, malignancy. So it's very important to find what risk factors were associated with the MAFLD progression. And we can categorize this risk factor into two groups. The first one is at the left side is non-modifiable, including age, gender, race, and the genetic background. And the second category is the modifiable risk factor, including obesity, sedentary behavior, exercise, diet, and alcohol. And recent evidence also shows that the baseline histology in terms of inflammation and fibrosis also could be modifiable after the intense exercise and diet control. So this large-scale study from 23 centers in Europe, in 10 European countries, consisting of around half million participants with a median follow-up period of around 15 years, and try to evaluate the role of physical activity in the risk of hepatocellular carcinoma. As you can see in the left side figure, the HCC incidence was highest in the patient with inactive physical activity, followed by those with moderate inactive physical activity, moderate activity, active physical activity, and lowest in the patients, in the participant with active physical activity. So the overall risk could be, CC could be reduced for 45% among the participants with active physical activity. If we stratify the physical activity into so-called vigorous and non-vigorous, is take the cut point at 2 hours per week of physical activity. As you can see, the subjects with vigorous physical activity could reduce the HCC risk by 50%. Indicate the physical activity is very important in the risk, in the HCC risk in the general population. So why the exercise could have effect on the control of long-term mortality as well as the disease progression of MAFLD? It's because the aerobic exercise could activate the lipolysis, upregulate the UCP1, pipa gamma, and alter the adipocytokine. And also the recent exercise could lead to hypertrophy of type 2 muscle fiber, activation of glucose transporter 4, AMPK, and alter the mitochondria. Taken together, though we have a change in the liver in terms of increased peripheral insulin sensitivity, decrease the de novo lipogenesis, decrease the visceral fat, and increase the clearance of very low density lipoprotein. So that the most of the aerobic and resistant exercise could reduce the intrahepatic fat and with regression from the MAFLD to normal liver. So talking about the intensity of the exercise, usually we can divide the intensity by so-called metabolic equivalence, the MET. It's defined as the amount of oxygen consumed by sitting at rest and equal to 3.5 milliliter oxygen per kilogram body weight multiplied the minute. For the moderate intensity physical activity, require a moderate amount of effort and noticeable accelerated heart rate. It's around 3 to 6 minutes. For the vigorous intensity of physical activity, require a large amount of effort and cause rapid breathing and a substantial increase in the heart rate. It's approximately more than 6 minutes. So with the aerobic or the resistance exercise, you can expect to have an improvement of MAFLD. But only vigorous aerobic exercise can improve the NASH, and only double vigorous aerobic exercise can improve both of the NASH and liver fibrosis. So in this randomized clinical trials, try to evaluate the exercise without the body weight loss on the therapeutic effect of the patient with NASH. For 24 patients with biopsy-proven NASH was assigned to receive exercise or cellular care for 12 weeks while maintaining the body weight, as you can see in the right side figure. for patients with SI, they could have a significant decrease in the hepatic triglyceride content and also the visceral fat, and also decrease the plasma triglyceride level and gamma GT level. However, there are no effects of the SIs on the LT level, metabolic parameter, inflammation markers, and fibrosis, indicating the SIs without the weight loss can only significantly reduce the steatosis and plasma TG level, but did not affect the NASH inflammation and fibrosis. So this study tried to evaluate the impact of body weight loss on the NAFLD by lifestyle modification. Around the 300 biopsy-approved NASH patient was assigned to receive 52 weeks of lifestyle intervention, including dietary restriction and 200 minutes work per week. As you can see, if the patient could have a body weight loss more than 5%, the patient will have a significant percentage in the NASH resolution, fibrosis regression, and steatosis improvement. And as shown in the other study, for patients who can have a weight loss between 3 to 5%, we have to improve the steatosis. The weight loss between 5 to 7%, we have the improvement of liver cell injury and inflammation. And the 7 to 10% of the weight loss will improve the liver biochemistry, or feature NASH, and even fibrosis. And if the patient could have a 10% or more body weight loss, half of this patient will have a fibrosis regression, indicating a greater extent of the weight loss, ideally greater than 77%, induced by the lifestyle change, is associated with the level in the improvement of NASH resolution and fibrosis regression. How about the effect of exercise of lifestyle intervention on the so-called lean NASH, the lean NAFLD? This study conducted by Professor Vincent Wang from Chinese University of Hong Kong, consisting of 154 community NAFLD patients randomized to receive a 12 months lifestyle intervention involving regular exercise or to a 12-week standard care. The primary endpoint was remission of NAFLD at month 12. As you can see, for patients with body mass index less than 25, denoted by the light blue bars, even the patient with a little bit, very few body weight loss, less than 3%, they still have 14% of the patient will have NAFLD remission, and the proportion of NAFLD remission increased to 50% for patients with weight loss from between 3 to 5%, and reach 100% for the patient with weight loss greater than 10, indicating the weight loss will also have benefits in decreasing or reduce the intrahepatic fats in the non-NAFLD patients. We all know that the diet control is very important in the NAFLD management, especially the Mediterranean diet. And this study, the Red Plus, tried to evaluate the green Mediterranean diet's effect on the intrahepatic fat. The green Mediterranean diet is amplified with green plant-based protein, polyphenols such as mankai, green tea, and walnuts, and restricted in red processed meat, compared to the patient with traditional meat diet and the patient with health diet guideline. As you can see, the group of green meat diet group have a highest weight change around the 6 kilograms at 6 months. Followed by the MET diet group with 5 kilogram reduction of body weight at 6 months, and only 1.5 kilogram reduction in the health diet guideline control group. And as you can see, the green bars demonstrate the green MET group could have a highest liver fat change at minus 37% compared to only 17% in the MET diet group. And not only the intrahepatic fat loss, the green MET diet also improved the serum folate, adipocytes, lipid biomarker, and change in the microbiome. So this new diet strategy of green MET diet amplified by the green plant-based protein polyphenols could double intrahepatic fat loss than the other hairstyle control. So for the ESO recommendation in the lifestyle modification for MAFLD was published in 2021, recommended increase the omega-3 fatty acid found in fish, walnuts, and utilize the olive oil and minimize the fast food and ultra-processed food, and try to follow the Mediterranean diet patterns and avoid added sugar and also the sugar-sweetened beverage, and reduce the saturated and the cholesterol contain diet. And also recommend the physical activity with aerobic exercise of 3 days or more per week, and 150 minutes or moderate intensity exercise or more per week. And also recommend resistance exercise 2 days or more in 1 week, and reduce the so-called sedentary behavior. So we all know that the nature cause of NASH and NAFLD, they are bidirectional dynamic. As you know that the instance of each category is around 28 to 52 cases per 100 person year from case liver to NAFLD, 71 to 93 cases per 1,000 person year from NAFLD to NASH, and 61 to 58 cases per 1,000 person year for fibrosis progression. But in the nature cause, there are also you can also see the regression from the NASH cirrhosis to NASH, from NASH to NAFLD, and from NAFLD to so-called healthy liver. So it's very important to know what factors will accelerate the progression of the from the NAFLD to NASH and NASH fibrosis. And if we can control this better, we might have the potential benefit to have a regression from the advanced NASH patient to minimal NAFLD condition. So this study, large scale study, considered more than 271,000 patients in US-VS study with 9 years follow-up. They found the metabolic trait, including the obesity, hypertension, diabetes, and dyslipidemia, are highly associated with cirrhosis or HCC occurrence. And also to observe a stepwise increase in risk with each additional metabolic trait, with a hazard ratio of 1.33 if the patient had 2 traits of metabolic dysfunction, up to 2.03 if the patient had a 4 traits of metabolic dysfunction. And also we can see the hypertension had the highest odds ratio of cirrhosis development, and the diabetes had the highest odds ratio of HCC development. So you are curious whether there are interaction between the fatty liver severity and the incidence of hypertension and diabetes. In this study we collected more than 41,000 subjects who received health check-up in Gaucho Medical University Hospital, and you can see the patient with moderate to severe fatty liver had highest prevalence rates in hypertension at 25%, and diabetes at 8% when compared to those without the fatty liver, 7% and 1.5% only. And in the longitudinal follow-up of more than around the 3,500 patients with mean follow-up period of around the 6.5 years, we can see, again, the patient with moderate to severe fatty liver have a higher incidence rate of hypertension and diabetes when compared to the patient without fatty liver. So with odds ratio of 1.28 and 4.9 respectively. So if the patient could have reverse the fatty liver from moderate severe to no fatty liver, or from mild fatty liver to no fatty liver, the risk of hypertension and diabetes could be decreased with an odds ratio of 0.66 and 0.2 respectively. But if the patient developed of the fatty liver degree accelerated from no fatty liver to mild or moderate severe, or from mild to severe, The incidence of hypertension and diabetes also increased with odds ratio of 1.5 and 1.76, and 2.2 and 2.8 in the diabetes the incidence, indicating the development or regression of fatty liver increased the risk of hypertension and diabetes, and conversely, regress or resolve fatty liver could reduce the risk of hypertension and diabetes. We also interested in the role of the so-called cardiometabolic risk factor. That means the obesity, pre-diabetes, pre-hypertension, higher triglyceride level, and low HDL level. As you can see, the higher the cardiometabolic risk factors, the higher risk of the hypertension and diabetes, with the odds ratio of 2.02 with one cardiometabolic risk factor to up to 15 odds ratio in the patient with 5 cardiometabolic risk factor in the risk of hypertension. Similar result was found from 2.9 to 82 in the hazard ratio for the risk of diabetes, indicating that in the increase in the number of cardiometabolic risk, the higher the incidence of new onset hypertension and diabetes. Similarly, if we're looking at the dynamic of the burden of cardiometabolic risk, stratified or hitchwise stratified minimal is CMI 0 or 1, moderate CMI 0, 2 or 3, or significant burden CMR 4 or 5. As you can see, the dynamic change, the increase of the burden will increase the incidence of hypertension, diabetes, and the decrease, the green color decrease of the CMR burden will also decrease the risk of hypertension and diabetes. Therefore, the 3 major society or liver society recommend the lifestyle interventions. It's quite similar. I just focus on the ESO guideline they recommend greater than 5% of weight loss for steatosis, 7 to 10% for loss for NASH, greater than 10% loss for fibrosis, and ask 500 to 1,000 kilocalorie deficiency and aerobic and resistance training, more than 150 minutes per week, and low to moderate fats and moderate to high carbohydrate intake. And the double accelerator also recommend at least 3 cups of coffee for the patient with advanced fatty liver. However, the top mission to achieve the goal of weight loss is that only 30% of patients could achieve weight loss of greater than 5%, and only 9% have 7 to 10% weight loss, and 10% of patients have 10% weight loss, indicating only 12.5% could achieve lifestyle modification, achieve fibrosis regression. Therefore, we recently joined the Society of Cardiology in Taiwan and published the position statement and recommended the weight reduction remain the cornerstone of non-pharmacological management for MAFLD. However, the long-term weight control is still a critical issue because it's not easy to maintain a sustained weight loss. So in summary, amenities still exist in the MAFLD management. So exploration of effective drug of MAFLD and MASH treatment is a clinical challenge. Although recently approved agent, the desmetron, the thyroid hormone, receptor beta agonists have been approved in the treatment of NASH, the long-term effects and safety of this agent remain to be clarified. So lifestyle modification is highly recommended to mitigate the NASH and improve the both of the hepatic and extrahepatic outcome. Aerobic resistance exercise, vigorous aerobic exercise to improve the NASH, and the double vigorous aerobic exercise to improve the NASH and fibrosis. And the most important point, the ultimate goal of NASH control is to have to reach the significant and sustained weight reduction, ultimately 7 to 10% for fibrosis. But for lean NASH, maybe 3 to 5% of weight loss is enough in the control of the NASH. Thank you very much for your attention, and welcome to Kaohsiung in this June.
Thank you very much for a nice presentation. Now this presentation is open for discussion. Any question, comments from the audience? And yeah, I'd like to ask about the diet. Probably in your country, the most prevalent food would be the Chinese cuisine, and probably the fat content may be higher. But what do you recommend the patient to the dietary restriction? Do you recommend vegetarian diet to the patients, or how do you modify?
Oh, okay. I think in Taiwan there are we have many kinds of the cuisine, not only the Taiwanese style, the Chinese style, Japanese style, European style. But as I mentioned, we try to recommend the olive oil in the routine cooking, especially at home. And also we encourage the fish intake because the Taiwan is island countries is among there's a lot of the fish, however the freshwater fish or seawater fish. And recently we recommend to avoid the processed meat. I think it's very important because in the past, because it's not easy to preserve the meat. So a lot of the meat, especially the pork and even the pork or the duck, they are processed meat. But recently, we are recommended not to enjoy the processed meat too much.
There are a variety of vegetable oil, and probably the Chinese use a variety of vegetable oil rather than the olive oil. But do you recommend olive oil?
Yeah, because olive oil is not only plenty of the omega-3 unsaturated fat, but it also have a high meal point. I think it's very good, it's very important for cooking because it can tolerate to high temperature. I think it's another point when compared to the other soy oil, soybean oil. Yes.
Now the price of olive oil is increasing, so that's kind of problem worldwide, I think. Anyway, any other questions, comments? Please.
For a nice talk. What do you think is the major cause of dietary failure? I'm particularly interested in neurobehavioral reasons of not sticking to the diet and all those things.
You mean the failure to the diet control?
Yeah, you said only 9 to 10% of the people would actually be able to lose some weight and then maintain that. And of course, the caloric intake is a major cause of regain and all this. So what do you think are the major barriers, especially why do the people go back to gaining the weight and taking these calories?
Yes, I think it's the sedentary lifestyle, and also right now currently most of the people are under work, but it's very difficult to maintain the diet control and exercise. If you have a regular work, maybe you have an additional work, so you have no time to deal with the food, no time to follow the exercise request. So I think it's very important to increase the disease awareness, not only the patient population, but also the stakeholder, especially the government, have to encourage the industry and all the company to have a regular session for the employee to have an exercise program and also provide the so-called healthy food when they are working.
And I have another question about exercise. You mentioned a lot about exercise, and probably most doctors believe that exercise is beneficial for the reversal of the liver disease. But you mentioned that the strength of the exercise is important. But on the other hand, the patient with morbid obesity cannot exercise a lot. and probably the durability of to the exercise may be the problem. How do you think about it?
Yes, I think it's a challenge, especially the aerobic exercise for the patient with comorbid obesity. But I think the recent exercise is okay for this patient population. So that's why I recommend not only the exercise, we also to accompany with the diet control is very important. Exercise alone will not be enough.
And keep doing the exercises very difficult.
Important. Yeah.
In those patients, so that can be a problem. Anyway, your presentation is very informative, and thank you again for
Thank you.
nice presentation. So the third speaker is Dr. Masahito Shimizu from the Department of Gastroenterology, Gifu University Graduate School of Medicine, Japan. His title of talk is NAFLD, NASH, and Sarcopenia, Usefulness in Nutritional and Exercise Therapy. Dr. Shimizu, please.
Okay. Thank you very much, Professor Ikejima. So my name is Shimizu from the Gifu University. First of all, I would like to thank organizers for giving me an opportunity to do a presentation today. So today I would like to give a lecture entitled NAFLD, NASH, and Sarcopenia, Usefulness of the Nutritional and Exercise Therapy. So this is my COI. So both exercise and nutritional therapies are the basic treatment for NAFLD NASH. Today, in the first part, I talk about the exercise therapy, especially focusing on the sarcopenia and liver rehabilitation. And in the second part, I talk about the nutritional therapy, so especially focusing on the dietary habit, dietary recommendations, and the impact of BCAA, branched chain amino acids, which is a key drug for complication of cirrhosis, but may need some attention in patients with NAFLD. So the first part is about the exercise therapy. I come from the Gifu, the center of Japan. There are very beautiful nature in our prefecture. So I think the swimming in the Nagara River and catching the fish using bird and climbing Gifu Castle, located in the top of the mountain, will be helpful to prevent sarcopenia. Okay, the sarcopenia is defined by the skeletal mass loss and the muscle dysfunction. The sarcopenia is classified into primary and secondary types. The primary sarcopenia is aging-related sarcopenia, whereas secondary sarcopenia is reduced muscle mass and strength that accompanies an underlying disease. The secondary sarcopenia due to nutritional disorders can frequently occur in liver disease, including cirrhosis and NAFLD NASH. In 2016, the Japan Society of Hepatology JSH made an own assessment criteria for sarcopenia in liver disease. When examining a patient with liver disease, we must measure the grip strength and assess the muscle strength. If patients have muscle weakness, we need to measure the volume of skeletal muscle by using the CT scan or bioimpedance method assessment. So patients are diagnosed as sarcopenia when both muscle strength and mass are reduced. Sarcopenia, the skeletal muscle is one of the critical targets to prevent the development of hepatic failure and improve the QOL and prognosis of the patient. So we can say that the skeletal muscle is a second liver. So sarcopenia and NAFLD NASH have been reported to be strongly associated in the guidelines established by the JSH and the Japan Society of Gastroenterology, JSGE. In 2020, the one FRQ, future research question, is shown. So the question is that are sarcopenia and NAFLD NASH pathophysiology related? Of course, the answer is yes, that the patients with sarcopenia have an increased risk of NAFLD NASH. suggesting that the NAFLD, NASH, and sarcopenia interrelated by insulin resistance, lower levels of IGF-1 or chronic systemic inflammation, abnormalities in hepatokines, and lower levels of vitamin D. So overnutrition increases the risk of sarcopenia. The insulin resistance, systemic inflammation, and increased oxidative stress associated with overnutrition and obesity exacerbate the sarcopenia. So, and the pathologies are closely related to the development of the progression of NAFLD NASH. So, increased adipose tissue, especially in patients with cirrhosis, has a negative impact on liver failure and sarcopenia. So, liver failure, protein energy malnutrition, obesity, and sarcopenia develop a negative spiral as a series of pathological conditions. So leading to increased complications and decreased prognosis and QOL is strongly associated with this negative loop. So moreover, it is also reported that sarcopenia increases the risk of NASH independently of the insulin resistance and BMI, and also increase the risk of fibrosis progression. In 2021, based on the advice from the Professor Nakajima, the next speaker, and Professor Okanoue, the discussant of this session, so we summarize evidence-based interventions for lifestyle modification, including the diet, exercise, and sarcopenia in the treatment of NAFLD patients, especially in Japan and Asian countries. The most important advice of this review is that lifestyle-related intervention, including diet and exercise, to achieve weight loss is recommended for all NAFLD patients. This expert review makes several important recommendations regarding the exercise. The weight reduction is the basic treatment for NAFLD, and exercise is important, especially in the elderly and lean patients who need to watch for sarcopenia and frailty associated with loss. So they have a very high risk for frailty and sarcopenia by weight loss. So low-intensity exercise recommended for such patients. However, a beneficial exercise program has not been elucidated for patients with elderly and lean NAFLD patients. The regular exercise is also recommended for patients with NAFLD. The recommended target protocol is shown in this slide. So the red one, such as running and swimming, is a highly intensive exercise. So the recommended target protocol is here. So before beginning, such as high-intensity exercise, the cardiac function should be assessed in patients at high risk for cardiovascular disease, and especially the elderly people. So the intensity of exercise should be carefully considered for patients with decompensated cirrhosis and the elderly people. In 2023, the JSH established the liver rehabilitation guidelines. Sorry, it is written in Japanese. So liver rehabilitation is a comprehensive long-term program that includes exercise, nutrition, medication, education, and psychological support, with the goal of improving the symptoms and life outcomes associated with liver disease. Proper implementation of liver rehabilitation is essential, I think, to improve the sarcopenia, liver function, prognosis, and QOL in NAFLD NASH patients. So European and US guidelines were consulted in the preparation of this Japanese guideline. So this guideline indicates the specific exercise regimen. The guideline pointed to some important comments that the exercise therapy alone improved the liver function and hepatic steatosis in patients with NAFLD. The continued aerobic exercise improves the steatosis without weight reduction, and exercise intensity above moderate is more useful in improving steatosis. Of course, both the aerobic and the resistance exercise are useful in improving liver steatosis. However, the resistance exercise has been reported to improve NAFLD with less energy expenditure. So therefore, the resistance exercise may be more feasible than the aerobic exercise for NAFLD patients with impaired cardiorespiratory function or those who cannot tolerate or participate in the hard aerobic exercise. So there may be a direct link between the resistance exercise and the hepatic lipid metabolism. We investigated the exercise habit in patients with chronic liver disease, CLD. So as shown in here, the 55% of CLD patients were physically active less than once a week, and many patients expressed concerns about the physical fitness and inactivity. However, they were willing to increase their frequency of physical activity, and walking was the number one activity that they would like to try in the future. So patients with CLD are inactive and need physical activity interventions, especially walking. So the second part is about the nutritional therapy. The Hida Takayama is a mountain area of my prefecture, Gifu. It's a very beautiful historical district. So the Hida beef, the Wagyu, is one of the top brands of the Japanese beef. It's very delicious, tasty, expensive. And it is oily, so I'm not sure it is good for NAFLD NASH. So the experts review of NAFLD also makes several important recommendations regarding the diet. First of all, the total energy intake should be optimized. Carbohydrate-restricted diet can reduce liver fat. The Japanese and/or Mediterranean diet are recommended. The intake of fructose should be restricted. It is also important to change dietary habit, such as frequent eating, the fast eating, or breakfast skipping, and nighttime snacking. This slide summarizes the dietary standards recommended by the JSGE, JSH, and the Japan Diabetes Society. So for dietary interventions for obese NAFLD patients, the low-calorie diet was prescribed in all these guidelines. Calorie restriction is highly beneficial for patients with NAFLD. The energy ratio during a caloric restriction is 50 to 6% carbohydrate and 20 to 25% lipid, and all guidelines recommended a fat-restricted diet. Only the Diabetes Society guideline limits the protein up to 20%. But I'm not sure if this is appropriate for the NAFLD patient who must watch for sarcopenia. So there is no mention of appropriate amino acid intake. The branched-chain amino acids, BCAA, including the valine, leucine, and isoleucine, are essential amino acids and are involved in the pathophysiology of many liver diseases. The BCAA play a critical role in the metabolism of protein, glucose, and fats. BCAA can stimulate protein synthesis and inhibit protein degradation. So BCAA is also used as an energy source. Therefore, the BCAA is a key drug for nutrition therapy and of liver disease, including sarcopenia. So we reported that the child class B and C, the lower BCA supplementation, and the complication with sarcopenia are independently associated with mortality in patients with liver cirrhosis. The mortality of sarcopenia and cirrhosis was significantly higher than that of non-sarcopenic patients. We also found that in Japanese cirrhotic patients, age 70 years over, the lower BMI and lower BCA serum levels are significant predictors of sarcopenia development. So BCAA is important for maintaining and increasing skeletal muscle mass. The protein energy malnutrition can promote the degradation of skeletal muscle by requiring the skeletal muscle to supply the glucose and BCAA as an energy. So therefore, the decreased BCAA and low activity are key mechanisms for developing sarcopenia, and BCAA supplementation and exercise might be effective strategy for the treatment of sarcopenia. So in the Japanese guideline 2020 for liver cirrhosis, it is stated that the exercise and the nutrition therapy is proposed as a useful treatment for sarcopenia associated with cirrhosis. As nutrition therapy, BCAA, especially leucine, might be effective. The exercise is also beneficial to keep the skeletal muscle mass and strength. So as an important point, we found that BCAA supplementation can improve the survival of sarcopenic patients with cirrhosis. The BCAA exerts a beneficial effects on the prognosis of liver cirrhotic patients, particularly when they have sarcopenia. Of course, moreover, the combined exercise BCAA therapy has been reported to improve sarcopenia. In these trials, the BCAA supplementation with a right-wing snack and walking exercise was reported to be effective in improving the muscle volume and strength in cirrhotic patients. These reports demonstrate the usefulness of liver rehabilitation. Interestingly, the BCAA administered for a long period inhibits the liver calciumgenesis in obese patients with cirrhosis. BCAA also significantly inhibits liver calciumgenesis in obese mice model. So therefore, in patients with MAFLD, who is often complicated by obesity, it may be advisable to use BCAA preparation aggressively to prevent liver calciumgenesis in addition to preventing sarcopenia. However, the several reports have revealed that abnormal or imbalanced intake of BCAA may promote the development and progression of diabetes, insulin resistance, and even MAFLD-NASH. So the plasma levels of BCAA were found to usually decrease in patients with cirrhosis, but increase in obese and MAFLD-NASH patients. So because over intake of BCAA are rapidly broken down and additional supplementation with BCAA may not promote the protein albumin synthesis in MAFLD-NASH patients. So therefore, it is necessary to carefully examine whether simple supplementation with BCAA improve the liver pathophysiology or worsen the abnormal glucose metabolism in MAFLD-NASH patients. So BCAA replacement therapy may not be necessary, at least in simple MAFLD patients without fibrosis, but it might be necessary when liver cirrhosis develops, even in NASH. So Hippocrates, the father of medicine, left many aphorisms, such as walking is the best medication, better medicine to us, human beings, and any disease can be cured by dieting and exercise, which are same as management for MAFLD-NASH. And Hippocrates also said that all disease begins in the gut. But if he is living now, he may say that all disease begins in the steatotic liver. So excuse me, but I spoke for him. So this is conclusion. It is critical to develop the safe and appropriate liver rehabilitation to improve the prognosis and QOL of NAFLD NASH patients, especially who has sarcopenia. Today's presentation is supported by my laboratory members, especially thank for Drs. Hanai and Mira. Thank you very much for your kind attention.
Thank you very much for a comprehensive talk about sarcopenia and also nutritional support. Okay, Dr. Kong.
Thank you very much. Very excellent talk. I'm Kazuyoshi Kon from Juntendo University in Tokyo, Japan. And as you told, avoiding sarcopenia is a very important issue for MAFLD, but it's very hard and often hard to increase muscle volume in patients, especially in elder. Then sometimes I need to consider which value should be set as a target. Should they increase the muscle volume or just keep the volume in the muscle from the basal levels?
Okay, thank you very much for the important question. And I agree with your suggestion. It is very difficult to increase the skeletal muscle volume or skeletal muscle function. So our purpose is to keep the skeletal muscle volume. So usually we lose the 2% of muscle every year by aging. And when we have a liver disease, the speed is more rapid, the 5 or 6% every year. So in order to prevent the rapid skeletal muscle decrease, so we must target the skeletal muscle keep is important. Yes, thank you.
Thank you very much.
All right.
I'm interested in your BCAA. Do you use this routinely for your patients with MAFLD? Because most of our patients with MAFLD have diabetes as a background. And we noticed that the glucose increases after the intake of BCAA. Yeah. So how do you now negotiate? Do you increase your glucose intake, your glucose hypoglycemic drugs when you give BCAA, or is it wiser not to give BCAA alone in a subset of patients? Because I know for a fact that you can have translation of protein in leucine, but in valine, it becomes problematic for insulin resistance, especially in a high-fat diet.
Yes, thank you very much for important suggestion. So I think the most important thing is to find out the point when the BCAA can start to decrease. So when the patient have cirrhosis or severe fibrosis, if they are NAFLD, the BCAA levels sometimes decrease when they have cirrhosis. So the important point is to find such a point, changing point. And I think also important point is only BCAA intake is not recommended, but the combined the intake of BCAA plus exercise, it might be recommended for the MAFLD or NAFLD patient, but I don't have enough evidence, so I want to try the clinical trial. Thank you.
I have one question. Nowadays, we can get the protein powder and a drugstore, and most people favor taking protein powder. And we often see the patient of MAFLD with muscle loss, even though they are not cirrhosis. Do you recommend BCAA or regular protein powder to those patients?
I think I have some COI, but I recommend have a BCA supplementation from the hospital is more beneficial for such patients. And the important advice is that only BCAA intake for healthy people is risky, but they may have diabetes or obesity. So the more important point for healthy people who want to take BCAA is you must do exercise.
So the combination exercise very important.
Right.
Yeah. Okay. Thank you very much for your nice presentation.
Thank you very much.
Okay, the last speaker of this session is Dr. Atsushi Nakajima from Department of Gastroenterology and Hepatology, Yokohama City University School of Medicine, Japan. His title of talk is Clinical Management of MAFLD Medications. Dr. Nakajima, please.
Thank you, Chairman, for inviting me to such a nice meeting. So unfortunately, I have 4 minutes left. so the time is very important, so it's COI. So my topic is about the medication for MAFLD, MAFLD recently. So to see the phase 3 result, as you can see, the right panel, there is 2 kinds of phase 3 study met the primary endpoint. The right one is obeticholic acid, OCA. As you can see here, the NASH resolution achieved 23% compared to 12% of placebo groups. And the left panel, you can see here the recent published New England Journal of Medicine, phase 3 randomized control trial of resmetirom, which is a thyroid hormone receptor beta agonist. You can see the left graph, about 30% of NASH resolution compared to 90.7 placebo effect. This drug has been approved by the FDA a few days ago. And very exciting point is indication, label. I don't know the label, but the indication will be using this drug without liver biopsy. And this drug can be prescribed by the endocrinologist or primary care physician. But the right side, the obeticholics are not approved. So you remember the NASH resolution is 30% in resmetirom. Obeticholic acid, 23%. So for the phase 2 study, we can see the landscape of the phase 2 study. There are a lot of pipeline. And in right side one, GLP-1, semaglutide meet the phase 2 outcome. And now under phase 3 trial in the global level. And other pipeline is a very promising candidate for the phase 3 drug. And recent top data released by the pharmaceutical companies, it's not paper published, but it's just a site from the website of the pharmaceutical companies. But we should wait until the paper published. But for example, the GLP-1, the GIP dual agonist, tirzepatide achieved 73.9 MASH resolution. Complete resmetirom or obeticholic acid, 30% or 23%. 73.9% MASH resolution is incredible. And also the GLP-1 and the glucagon dual agonist company's website shows 83% MASH resolution, vs 18% of placebo. So, but in many Asian countries, for the time being, resmetirom will not be used. So, now we have to choose a treatment option recommended with the existing drug for the metabolic disorder such as diabetics or dyslipidemia. So this is a flow of Japanese guideline. As you can see here in lower right bottom, with the type 2 diabetes, the Japanese guideline recommended that chiazolidine such as pioglitazone, and GLP-1 analog, such as semaglutide, and SGLT2 inhibitor. And for the dyslipidemia, the statin is recommended. In the hypertension, ARB or ACE are recommended. So for the diabetes, Japanese guideline recommended 3 kinds of diabetic drugs. As for the SGLT2 inhibitor, which is regularly used for the treatment of diabetes, but no RCT and single theta. No evidence for long-term effect of MAFLD. No histological evaluation, including fibrosis and NASH. So we concluded multi-center RCT to investigate the treatment effect of ipragliflozin. This is one of the SGLT2 inhibitor for the patient with biopsy-proven MASH for 72 weeks. This is a study design. So the biopsy-proven patient are randomized, and the treatment effect, period is 72 weeks. And end of the treatment, the biopsy is performed. This is a basic background. As you can see here, SGLT2 inhibitor, ipragliflozin, ameliorate glycemic control and obesity, and also the liver functional test improved significantly. You know, the reduction by AST, reduction by ALT, reduction of GGT, and the reduction of type 4 collagen 7S. Important thing is ipragliflozin improved hepatic ballooning and liver fibrosis. As you can see here in the ballooning part, the 100% of ballooning improved in ipragliflozin groups, and the fibrosis 70% improved. This is a safety assessment. There's no serious adverse event. So conclusions or treatment with SGLT2 inhibitor, ipragliflozin, for MAFLD patient with diabetes lead to histological improvement, as well as ameliorated glycemic control and obesity. And the second drug is dyslipidemia, and only a statin is recommended in Japanese guideline for dyslipidemia. But how about hypertriglyceridemia cases? So as you can see here, using a big healthcare database, we analyze the hazard ratio of cardiovascular event in MAFLD patient with or without diabetes and hypertriglyceridemia. As you can see here, with diabetes, the hazard ratio is 1.46, and with diabetes, hazard ratio is 2 points. But combined hyper-TG and diabetes, the hazard ratio reached about 3.0. So for the hyper-TG, the use of fenofibrate on cardiovascular outcome in statin users with metabolic disk syndrome, propensity matched cohort study show that compare the statin-only treatment, combine statin plus fenofibrate, significantly reduce the cardiovascular event. So, but you know, the fenofibrate is sometimes cause liver function abnormality. So recently in Japan, selective PP-alpha modulator called SPAM alpha for hyper-TG has been approved. The MOA of the PPR SPAM alpha is shown here. You know, the left hand, normal PPR alpha agonists such as fenofibrate, bezafibrate, attenuate the gene expression non-specifically, but the SPAM alpha attenuate the gene selectively on target gene, especially, you know, this SPAM alpha target gene on the about lipidemia or the glucose metabolism. And turn off the unwanted gene expression, such as liver enzyme abnormality. So in Japan, the selective PPR alpha agonist, pemafibrate, which is now approved and reimbursed for the treatment of dyslipidemia. So this drug, during the phase 3 trial, in comparison to the fenofibrate, the pemafibrate, you can see pemafibrate reduces the ALT, AST, and creatinine levels. So you know, these patients are normal ALT, not a MAFLD patient. In this study, I think the pemafibrate is a good candidate for the treatment of MAFLD. So, but you know, the fenofibrate is sometimes cause ALT elevation. So we conducted a POC study using this pemafibrate drug for 24 weeks, placebo control study using the MAFLD patient. As you can see here, pemafibrate did not significantly reduce the liver fat content, but significantly reduced the MRE-based liver stiffness, as well as significantly reduction of ALT. And importantly, this drug is a treatment for the dyslipidemia. During this period, to see the lipid markers, as you can see here, the significant reduction of LDL cholesterol, non-HDL cholesterol, and the TG reduction. So in conclusion, the pemafibrate, a novel sperm alpha modulator, improves liver stiffness by MRE and serum liver and the lipid parameters in MAFLD. Pemafibrate is a good indication for the MAFLD patient with dyslipidemia. So this drug is approved in reimbursed Japan as well as in some Asian countries now. So last part of my talk is novel MOA. So now the several kind of MOA drugs has been investigated. One is a anti-metabolic drug, anti-fibrotic drug, and anti-inflammation drug. So, but I investigate the novel MOA, gut barrier function. Here you know the gut-liver axis may play an important role for the MASH pathogenesis. Disruption of intestinal barrier function has been reported in patients with MASH. Antibiotic therapy improved MASH. You know, taking the fructose, N-Sazole, PPI cause disruption of gut barrier function. So improvement of intestinal barrier function may be novel therapeutic target for MASH. So lubiprostone, prostaglandin derivative, widely used for the treatment of constipation, has preclinical evidence for improvement in intestinal barrier function. We conducted POC study to see the therapeutic effect of lubiprostone for the treatment of MAFLD through the improvement of gut barrier function. This is a study design. Patient number is 150, divided 3 arms, lubiprostone 24, lubiprostone 12 microgram per day, and the placebo group. As you can see here, the right panel, lubiprostone significantly reduced the ALT level for a long time period. And in the left panel, the MRI PDFF shows the treatment group significantly reduced the liver fat content measured by the PDFF. In the middle images, you can see the baseline MRI PDF 37.6%. But after treatment, just only a 12 treatment, getting down to 28%. The caveat of this study is lubiprostone repair the barrier function, intestinal barrier function. Intestinal barrier function is measured by the LMR. LMR is the gold standard for the gut barrier function. You can see the left bottom line, treatment group improved the intestinal barrier function. On the contrary, placebo group is not. So at the same time, improve the gut barrier function, concomitant the serum endotoxin level reduction, suggesting that this drug improve the intestinal barrier function, leading the reduction of endotoxin in the serum. So this is a summary. Recent new drug development trial have shown a very high efficacy result, such as resmetirom, phase 3 study, cilzepapam in Synergy, phase 2 study, and sarabotide, phase 2 trial. Pioglitazone GLP-1 and SGLT2 inhibitor are recommended to use in MASH patient with diabetes. Pemafibrate, which is a drug for the treatment of dyslipidemia approved in Japan and some Asian countries, is a promising treatment option for MASH with hyper-TG. Targeting gut barrier function in MAFLD may be the novel therapeutic target. Thank you for your attention.
Thank you very much for a very informative presentation regarding the novel medication for MAFLD. And any question or comments from the audience? Yes.
Thank you very much for a beautiful talk. So you show very beautiful data that the pemafibrate can improve the liver stiffness, but there are no change in the PDFF, the liver lipid levels. Why? What is the mechanism?
Yeah, it's a very good question. I don't know the answer, but you know the same class drug, bezafibrate, fenofibrate, effect the same. You know, no change of liver fat content. But you know the pemafibrate improve the liver function and the liver stiffness. I don't know the answer.
No, yeah. So the agents can improve the hepatic inflammation or cell proliferation? So
I
PDF is no
I think the drug power is more strong, so maybe the fat fraction maybe decrease.
Thank you.
And Dr. Kohn.
I'm Kohn from the University. Very good, nice talk. Thank you very much. Then I'm interested in your data of lubiprostone. Then is lubiprostone has sufficient effect against MAFLD even in alone, MAFLD therapy alone, or do you recommend to use lubiprostone combined with probiotics?
Yeah, it's possible, but you know there is no indication indication for the treatment. It's a POC study.
Thank you.
Thank you.
I have a simple question about lubiprostone. Does lubiprostone affect on the gut microbiota?
Yes, attenuate the gut microbiota, yes.
So probably a change in the gut microbiota may be beneficial for MAFLD.
Yes, but the main reason for the attenuation of gut microbiota is due to the gut barrier function repairing.
Okay, thank you. Dr. Okanoue, please.
Thank you very much for a very fantastic presentation. You showed that the endotoxin level is correlated with the gut barrier function. Are there differences of the serum endotoxin level in each stage of NASH? For example.
But this is not a biopsy proven data. So, you know, among the MAFLD patients, very heterogeneous. So some patients clearly getting down the endotoxin level in the serum, but some patient did not change. So that's why I think that this disease is not a homogeneous disease.
Yeah. Maybe you know the serum endotoxin level will influenced by the diet content of the diet.
Yeah, yeah.
How do you think about the fructose or some kind of this kind of food.
Yes.
Yeah.
There are so many papers that the fructose intake,
Yes.
fruits and vegetable, fruits, induce the gut barrier function disruption. So I think the fruit is no good for that.
I see.
Yeah.
And you showed many various kind of new drugs. At the present time, how do you think about the promising drug for the NASH patient at this present time?
Now that in Japan, the semaglutide is conducted a phase 3 trial, as well as Asian countries. This is most expecting promising drug. I hope so.
I see. Thank you very much.
Okay, thank you very much, Dr. Nakajima, for a nice presentation. And finally, I'd like to ask Dr. Okanoue for the comprehensive comment for the session. I'm sorry for the lack of the time, but...
Yeah, thank you very much for all speakers. All of them show us a very nice presentation, and maybe all attendants were very impressed by 4 speakers. So finally, Professor Nakajima told me that various kind of new drugs will be usefulness in near future. So we must wait few months or a few years, and then we can attend this kind of research work. Yeah, thank you very much for your attention. Thank you very much.
Thank you very much, Dr. Okanoue. And now I'd like to close this session. Thank you very much for attending, all the participants. Thank you. See you, Master.
Together? Yep. Thank you. Thank you. Thank you.